Good afternoon, everyone. And this is a lacrimal session, and in this word is given. And now we would like to start this lacrimal sessions. And as told by Dr. Khare, that time is only 6 minutes. Now we are going to start the session. The first paper in this, the presenting author is Dr. Purva Srivastav. Now I request her to kindly present his paper.
Good afternoon to all the dignitaries present over here. I thank AIOS for giving me this opportunity. I am Dr. Purva Srivastav, Senior Resident at Ellen Medical College Hospital, Bhopal. The topic of my presentation is role of radionuclide dactyoscintigraphy in evaluation of obstruction of nasolacrimal passage. First, with the introduction, dacryostenosis or NLDO, nasolacrimal duct obstruction, is one of the most common disorders affecting the lacrimal system. It may be congenital or acquired. Congenital NLDO may be observed typically within first weeks or months after delivery in approximately 6 to 20% of the newborns, whereas the acquired one is multifactorial. The etiology could be trauma, systemic diseases, neoplasms, radiotherapy, or chemotherapy. The patients may present with excessive tearing, epiphora, and ocular discharge, followed by redness and signs of inflammation around the periorbital area and the lids. Visual abnormalities and headache, symptoms such as headache may be the associated symptoms. Some facts about the history, how it began. In 1972, Razamondo et al. First introduced this concept of radionuclide dacryoscintigraphy following the installation of a drop of 99M technetium rhenium colloid into the conjunctival sac. This material spreads over the globe by capillary action, which is hence utilized in labeling the tears and outlining the drainage pathways. Sequential images are obtained, and normally the drainage into the nose is seen in the first few minutes. The aims and objectives of my study were to study the effectiveness of this technique in assessing the patency of the nasolacrimal passage and also locating the site of the obstruction so that further treatment plan can be decided, and also the prognosis can be explained to the patients. The material and methods. The study was conducted as an interventional study on patients presenting with chronic dacrocystitis at the Department of Ophthalmology at a tertiary care center of North India during the study period of approximately 18 months from 1st November 2019 to 30th April 2021. All the patients diagnosed as a case of chronic DC belonging to age range of more than 18 years and willing to consent were included. So the procedure was, all the cases were evaluated using a multiple converging holes collimator attached to a ECAM gamma camera with technetium 99M per technetate in the dose of 50 to 100 microcurie installed near the middle canthus into the conjunctival sac. That is, for this the patients, for obtaining the images, the patients were positioned sitting upright facing towards the gamma camera with the head fixed in an adjustable stand. About 0.1 cc of isotonic saline containing technetium 99M per technetate was instilled at the lateral canthus of each conjunctival sac in the lower fornix of the affected eye using an insulin syringe without the needle. Then, with the help of collimator attached to the ECAM gamma camera, high resolution images were acquired for about 20 minutes at about the rate of 1 frame per minute, and then the images were analyzed visually with the help of the nuclear medicine specialist as well. So this study did need the help of a specialist from other stream also. And then the obstruction, based upon the interpretation of the images, the obstructions were categorized as normal, that is notable drainage of activity from the lacrimal sac before the 5th minute of the study. Partial obstruction was delayed radio tracer washout from the sac. Complete obstruction was absence of notable radiotracer washout up to the end of the study. This data was analyzed with the help of MS Excel IBM SPSS software, version 20. Categorical variables were expressed as frequency and proportions, whereas continuous variables expressed as mean and standard. The results, 32 cases were analyzed. The mean age participants was around 50 years. Majority of the patients belonged to the 46-60 years of age category, and male predominance was there in our study. Out of the 32 cases totally analyzed, this procedure was suggestive of partial obstruction in 7 and complete in 22 cases, and no obstruction in 3 cases. And the site of obstruction, majority of the cases was at the neck of sac. So conclusion is, it is a non-invasive, safe and sensitive modality for evaluation of the obstruction of the or the patency of the nasolacrimal passage, and the dynamic flow of the radioactive materials is helpful in assessment of the functional integrity as well. However, there are some drawbacks, like with any other technique. There could be some cases presenting with allergy or anaphylaxis, so we have to stay prepared. And also there is this need of specialists like nuclear medicine specialists, and high cost of equipment, as well as the tracer material, along with a particular facility that we need for dilution and an expert to read the image. So these are the certain limitations. However, all in all, it's a sensitive and non-invasive safe technique. Some of the references. Thank you. Thank you for patient listening.
We may have one question from the audience. Anybody?
What is the time, how much time this reaches to the sac, and what is the time when reaching from the sac to the nasolacrimal, through nasolacrimal duct to the nasal mucosa, or to the
Inferior meatus.
So in total 5 minutes of time.
Right.
No, that there are two segments. One
Yes.
is from the conjunctival sac is go to the sac,
Sac.
and then from sac to the inferior meatus.
Yes.
So have you measured the time
Yes, sir. All in all, the duration was about 5 minutes.
total?
Yes.
Total
Till the
about 5?
mucosa. Yes, sir.
It reaches up to inferior meatus within a minute.
Yes, sir. 5.
It doesn't take 5
minute?
minutes. Have you compared the what was the status in anatomy details, anatomical details,
Like, sir, comparison.
with angio DCG?
Dacrocystogram. So dacrocystogram, I didn't compare it very objectively, but so this technique was more useful in evaluating smaller obstructions as well, which dacrocystogram missed. So it was more on the sensitivity scale. It was better. But objectively, we did not have any cases like proper data where we could compare.
Have you ever heard about the CBCT DCG?
No, sir.
Okay, one question from my side. A very good presentation. If you wanted to, since you have presented this study, if you wanted to use this for one clinical case scenario in your practice, where it offers advantage above normal sac syringing, what would that case scenario be? Since you're presenting a case study,
Yeah.
you should be knowing
Yeah.
how to imply
Imply.
clinically. So what would that case scenario be, where you would want to do a radionuclide scan over normal sac syringing or dacrocystography?
So the cases that they are having the clinical complaints, I mean the symptoms, but they came out to be normal or normal, I mean this other procedures, and also in the cases which are the post radiotherapy or chemotherapy cases.
Okay, so basically it benefits patients where we don't find an obstruction on syringing, but they
Yes.
still have
Having the
epiphora.
symptoms
So
clinically.
functional epiphora is a broad group which sometimes benefits by doing these scans.
So, okay, next. Now the next presenter, the paper is a prospective observational study on the tearing pattern of the preterm and term neonates. The presenting author, Dr. Shomi Kanji. Yes, she is here? No. The next paper is the modified Pawar intracystic implant in DCR. The presenting authors, Dr. Arya Wagner. Now please come and start your presentation.
Good afternoon. Good afternoon, everyone. Today I'll be presenting a paper on modified Pavar's intracystic implant in DCR surgery. So dacrocystal rhinostomy is the gold standard surgical treatment in which there is anastomosis of nasal and lacrimal sac mucosal flaps. The advantage being that since it is performed under direct visualization, it gives a highly predictable success rate of 90 to 95%. However, it has its own set of disadvantages as nasal packing becomes a necessity. It requires a large size ostium of 12 to 14 millimeter. There is more bleeding and tissue handling. It is contraindicated in children and old age, and it is more time consuming. So the Pavar's intracystic implant was developed by Dr. M.D. Pavar in 1985. Initially, it was made from the leftover silicone pieces used in hydrocephalus surgery, and it has undergone several modifications over the years. So the current implant that is available is made up of silicone, which is an inert material. It has a tubular shape with a collar at one end, available in three sizes of 13, 15 and 17 millimeter, and it has holes at the proximal and distal end which are 1 millimeter in diameter, which allows for better drainage. So the inner and outer diameter of the tube is 3 and 3.5 millimeter respectively. So the primary objective of the study was to assess the patency of the lacrimal duct, and the secondary objective was to evaluate the post-operative complications after insertion of this implant in dacrocystal rhinostomy surgery. It was a prospective longitudinal interventional hospital-based study in which 20 patients of chronic dacrocystitis recommended to undergo surgery were included. Cases having obstruction in the nasolacrimal duct were included, and patients who had obstruction at the common canaliculus or with fibrous sac or bleeding disorders were excluded. Complete preoperative ocular examination was done, and mainly sac syringing was done to confirm the nasolacrimal duct obstruction. So the surgical procedure was as follows, where a curved incision of 5 millimeter in length was taken on the skin along the anterior lacrimal crest. The medial canthal ligament was not cut in this procedure. Then the lacrimal sac was exposed with blunt dissection, and an anterolateral incision of 3.5 millimeter long was made on the anterior surface of the lacrimal sac. So a perforator of 3 millimeter in diameter was passed obliquely downwards through the sac to create an ostium through the lacrimal sac, the lacrimal bone and the nasal mucosa. Then the Pavar's intracystic implant was loaded on an introducer of 3 millimeter diameter and introduced into the sac with the collar lying inside the sac and the tubular end towards the nasal mucosa. Coming to the results, so the mean age of the patients in the study was 48 years of age, with the majority of the patients in the 40 to 60 years age group. 80% were females and 20% were males, giving a male is to female ratio of 1:4. So it was seen that out of the 20 patients, 17 patients showed patency on postoperative day 1, which improved to 19 patients on postoperative day 30, which was statistically significant. Coming to the postoperative complications, complications like lid edema and incisional edema, which was seen on postoperative day 1, resolved on the subsequent day 7 and day 30 follow-ups. Obstruction of passage was seen in 2 cases, which was due to crusting at the lower end at the nasal mucosa, which was removed endoscopically, and it was resolved by day 30. Sac infection was seen in 1 case, which persisted till day 30, resulting in failure of the surgery. So various studies by Mishra et al., Chandravanshi et al., and Anup Mondal et al. Have shown lesser intraoperative bleeding, intraoperative time required, and postoperative complications as compared to a conventional DCR procedure. So studies even comparing Pavar's implant versus a conventional DCR have shown a 96% success rate in Pavar's implant versus an 85% in conventional DCR, and even 97% in Pavar's implant versus a 94% in conventional DCR. So Pavar's intracystic implant has been shown to overcome all the shortcomings of a conventional DCR procedure in the following aspects, where nasal packing is not necessary. It is a small incision lacrimal bypass surgery. There is no need to cut the medial palpebral ligament. There is no need for creation of mucosal flaps and anastomosis. It is easy and less time consuming. There is minimal bleeding and postoperative complications, and gives a very favorable success rate. These are some of my references. Thank you. Thank you, sir.
This talk, but what are the difference? What are the complications you have noted in the Pavar implant versus normal dacrocystal rhinostomy or DCR cases? Because in this cases also there is a plugging of the
Yes, sir.
this Pavar implant
Yes, sir.
by mucus.
Yes, sir.
Have you noted
Yes,
these
sir.
complications of in this power implant?
Sir, in this study, I have done follow-up up to 1 month, but in long term, I have seen that there was such complications, and we have tried to resolve those with betadine wash, lacrimal massage, and another major complication that was seen even after 1 year was extrusion of the implant, sir. That was seen in one of the cases. So, apart from the one case with sac infection, sir, so that is maybe a potential long-term complication, sir. Extrusion of the implant through the incision site, even after it has healed very well, sir, and showed good patency over the immediate follow-up period.
So what was the total cumulative or mean follow-up period for all patients?
Sir, in this study I have done up till 1 month, sir, but I have observed over 1.5 years now.
Okay, no, but then this data is only of 1 year, because I have removed more power implants than I have put, and I have put 0. But the most cases where I have had to remove power implants have either been from the nose, from the middle turbinate, from the ethmoidal sinus, and one in from the maxillary sinus. And all of these are patients where obviously the implant was not placed there. So I think long-term implant migration is a serious risk.
Yes.
Serious.
And therefore longer studies
Have
in
been
terms of
required.
longitudinal follow-up is required to declare whether the surgery is actually
Yes, sir.
successful or
Yes,
not.
sir.
But good data that you've compared.
So in the two studies that you compared it with conventional DCR, you showed that the power implant has a success rate of 94 and 97%. Those studies, you need to mention the year, because conventional DCR right now, if you compare, is fairly successful. Secondly, the follow-up has to be mentioned,
Yes,
as
sir,
he
yes, sir.
said correctly, that we need to know how long the study with the power implant had a follow-up of versus the follow-up of conventional DCR.
Yes,
so
sir.
those 2 points could have been better in the table.
Yes, sir.
Okay. Okay.
Thank you.
Thank you.
Next one.
Next, prepare a case report of nasal lacrimal duct worm infestation. Dr. Purnaya.
Good afternoon, everyone present here. Myself, Dr. Pranaya Bashis. I'm a third year final student from AIO, Guwahati. And I'm going to present a case report on nasolacrimal duct worm infestation. On the history, we received a girl, of 8-year-old girl, presented in our OPD with a history of expulsion of tiny white worms from her left lower eyelid punctum for a period of 15 days. She complained that the worms were expelled while she sleeps or studies, or mostly during the night. She did not complain of any pain, swelling, or irritation in or around the eyes, and she complained of a warm sensation around her eyes, after which 1 or 2 small worms would come out. She was an average school-going girl without any systemic or past illnesses. Her bowel and bladder habits were normal. Her appetite has decreased, according to her mother, from the onset of the disease. Her sleep pattern was regular, and there was no significant family or allergy history. In this slide, we can see that there is a tiny small worm attached to her lower punctum, and it is a very, we took this picture just after the worm has come out from her punctum. On examination, her visual acuity was 6.6 for left eye. Her anterior segment was within normal limits with a very mild mucopurulent discharge from left eye. On syringing, the left nasolacrimal duct was found to be patent. Her left fundoscopic examination was found to be within normal limits. Her right eye was within normal limits. For management, we first hospitalized her in our ward. Then after admission, we saw that more fresh worms came out from her lower punctum, which we sent to the microbiological examination. Her routine blood workup along with stool and urine examination was done. Her blood eosinophilic count was slightly higher, that is 632 microliter, but no ova, cyst, eggs are found in her stool examination. Her routine urine examination was within normal limits. For treatment, she was treated with topical antibiotic eye drops and syringing of the nasolacrimal duct with gentamicin eye drops. Oral albendazole was prescribed after consultation with the pediatrician. After hospitalization and treatment, there was no fresh worms. And she was discharged from a ward after a period of 7 days and called for follow-up. Clinically, we found that the worms were threadworm, that is the or pinworm, Enterobius vermicularis. Her microbiological examination of the worms were sent, but sadly, because of the COVID situation, our patient did not came for follow-up with the results. That's all I can say. Thank you.
I think it's an interesting case, but I think without the documentation of the microbiological specimen.
Yes, actually, microbiology was sent. The report, it was the report we did not get, but we have confirmed with them since it the microbiology was sent in our same hospital. So I have confirmed that it is pinworm, but she did not come with the documentation because of all this COVID situation.
Possibly, if you want to present or write this up, you would need a photomicrograph of the worm to identify the species and confirm it.
Yes, sir. Yes, sir. Definitely.
And, you mentioned clinically you had confirmed that this was the diagnosis. How do you?
Sir, we have asked the microbiologist and about for gross picture of the worm. We have sent many worms actually with and then they have seen and confirmed that it is a pinworm, but the report wasn't collected and she did not follow up.
Right.
Are also seen in the conjunctival sac,
Yes, sir.
and
Yes,
these
sir.
worms may enter into the through puncta into the
Yes, sir.
or this usually happens sometimes due to insects. Some insects may
Insect after insect bite,
might
inoculation
might be the cause of
uh,
this worm. There
Yes,
might
sir.
be this might be one of the cause. Is there anything, sir? I think I have seen one case. One patient came and he is saying so that there is many worms in my worm. Then I have examined, and there were many worms in the conjunctival sac, and the history was that some insect was coming, and that due to insect on the eyes, and due to after insect, when insect the insect was not there, but there was many worms
yes, sir.
like poured in the conjunctival sac of that patient.
Yes,
So
sir.
it might be a cause due to that this worm may be there.
Yes, sir.
Okay.
Thank you, sir.
Our next speaker is Dr. Paridhi Todi. She is speaking on outcomes of canalicular laceration repair using intravenous cannula study of an economic approach.
Thank you, sir. Good afternoon, all. I am Dr. Paridhi, here to present on the study of outcomes of using an IV cannula to repair canalicular laceration. Canalicular system is affected in 16% of eyelid injuries following trauma, 50% of which also involve the canaliculi because of their exposed vulnerable positions in the lid. Repair of all these should be instituted because this may very well be the only working canaliculus of the patient. The aim is to provide endocanalicular support while repairing the laceration, which has been described as both mono and bicanalicular stents of silicon in the literature, but these are often prohibited due to their cost and immediate availability. So we came up with an alternative of using a 24 gauge IV cannula as an alternative to cater to those patients who could not undergo a silicon stenting. Patients who presented with the lid laceration involving either canaliculi were included. However, those with injury to the sac or the nasolacrimal duct were excluded and referred to an oculoplastic surgeon for expert management as well as their confounding effect on our study. So after primary treatment and tetanus toxoid injection in the OT, the wound was debrided, hemostasis was attained, and the use of adrenaline for this also blanched the mucosa and aided in identification of the cut ends of the canaliculus. If they were not seen, they were identified using a Bowman's probe, after which, similar to the action of a Bowman probing, the cannula was inserted, and bridging the gap, it was flushed with normal saline to confirm its position in the lacrimal sac. We aimed at retaining the hub throughout the procedure if the patient had good Bell's phenomenon to protect the cornea, as this would enable intraoperative maneuvering and cannulation in case the cannula came out, after which it was cut and anchored to the skin. Pericanalicular suturing is important in these cases to ensure that the healing occurs. Extubation was planned at 2 months based on experience with silicone stents. Anatomical success was defined as continuity of the canaliculus up to the sac by probing and getting a hard stop, and functional as absence of epiphora at end of the 3-month follow-up period. So during this 4 months study, 1 month was for recruitment, and we recruited 10 patients. All of them had a single canaliculus of the lower lid of only one eye involved, ranging from 13 years to 65 years. The most common cause was road traffic accident, followed by direct injury by a metal or a wooden rod and fist assault. And one elderly gentleman also presented following fall from stairs. The majority were males with a slight right eye preponderance, and no globe ruptures were seen. Most of our patients presented by 18 hours, with as early as 2 hours and as late as 48 hours. Extubation as planned was only done in 3% cases, and 70% were prematurely extruded. Anatomical success was seen in all cases, but functional only in 60% who had no epiphora. Watering was the most common complaint, and in 3 persons, this resolved 1 week postoperatively to asymptomatic levels with topical lubricants and persisted in the other 4. Foreign body sensation was also as common. Cosmetic embarrassment was seen, especially in the younger patients, one of whom was a schoolgirl who insisted on extubation within 2 weeks. Itching around the tube was also seen, and an interesting finding was the dilated punctum seen here in the photo, seen in 2 patients who were in whom the tube was kept in situ for more than 28 days. So this is pervasive among males, and we hypothesize their frequent involvement in road traffic accidents and physical fights. The main age of presentation continues to show a younger adult population, and the cause of injury had no outcome effect. All the patients from our study presented early, and since there was no delay in procurement of a silicone tube, they also gave good outcomes because the repair was instituted early. The dilated lacrimal puncta were, we hypothesized, caused due to the prolonged placement of the horizontal tube of a relatively inflexible tube. Functional failure in the 40% patients with anatomical continuity was due to loss of pump function, and higher extrusion was seen. Technique, we realize, has a few shortcomings. First, because of the smaller patient population, we could not find any with upper canalicular tears, so this may cause some ectropion with the suturing. Absence of epiphora may also be due to the patent upper canaliculus, which is a confounding factor in our study, and this will further be evaluated by lacrimal scintigraphy for functional failures and patent upper canaliculus in the following days. So to conclude, a closely fitting cannula can give good anatomical and acceptable functional outcomes, and this is especially relevant in those patients who cannot otherwise afford a silicone tube, and some attempt to prevent cicatrical closure gives good outcomes along with standard surgical practices. These are the references, these are the studies I have referred to. Thank you.
Okay, thank you for your good presentation. Excellent presentation. How will you confirm the other end of the this canaliculus? Because the end from the puncta, that can be easily visible, but other end sometimes is very difficult to find out the.
So we used 3 techniques. First was using adrenaline to blanch the mucosa. For those, sometimes the canaliculus was protruding from the proximal end, so it was easy to identify after blanching the mucosa, and visualization under the microscope helped. Also with Bowman's probe, we could dilate some, and after intubation with the canaliculus and flushing, we could assess that it is inside the lacrimal sac. So sometimes after flushing, we saw that it was not going up to the oropharynx. So after which, and after some more exploration, we found the ring-shaped structure in some patients of the cut end, and that was intubated. And after 2 or 3 tries, so when the flushed nasal saline was normal saline was reaching the nose, so we then proceeded to join those ends.
Okay. Sir.
What's the mean follow-up?
So we followed 9 patients till 3 months post-operatively. 1 dropped out after 2 months.
So, very nice presentation. I had done 2 cases of this when I was a resident, and the only problem I ever faced with these IV cannulas while passing through the canaliculus was early extrusion, because one end keeps hanging and it doesn't sit snug against the punctum. Is there any way, or did you use some method to secure the IV cannula so that it doesn't slip out or go in, causing a granuloma? And if not, then did you experience early extrusion? I must have missed that point where you had.
So early extrusion was seen in 70% cases.
Okay.
And 2 methods was, initially we kept longer ends, which caused more extrusion because the patient kept touching it, or it caused more foreign body sensations and irritations. So we shortened the end, and there was a suture passed through the canaliculus to the subciliary skin to fix it.
So in every case that was done?
So that was done from the beginning.
Okay, in all the cases?
Yes, in all time.
Next.
Thank you, sir.
Dr. Vaisali?
She is not here.
Dr. Alia Yami. She is speaking on bacteriological spectrum of gastrocystitis and their antibiotic susceptibility pattern.
A very good afternoon to everybody. I am Dr. Elia Yamin, and I will be presenting my paper on the bacteriological spectrum of gastrocystitis and their antibiotic susceptibility patterns. Gastrocystitis is inflammation of the lacrimal gland, which can be primary as idiopathic stenosis of the NLD or secondary to any trauma, tumor, infection, inflammation. So the microbiology of acute and chronic gastrocystitis infections may differ. It may shift over time, resulting in therapy failures. There can be geographical variation in terms of etiology, and the pattern and magnitude of antibacterial resistance may also differ from region to region. So if the treatment is started early, progression to chronicity, microbial resistance, and incidence of reoccurrence can be reduced with specific antibiotics to which the organisms are susceptible. It was a prospective observational-based, hospital-based study conducted from November 2019 to April 2021. First, the categorization of patients were done into acute and chronic on the basis of their signs and symptoms. The exclusion criteria for the study was children with congenital gastrocystitis, adolescents less than 20 years, insisted mucocele pyocele, common canalicular blockage, malignancy of sac, any maxillofacial trauma or surgery, any history of topical or systemic antibiotic in the past 1 month, recurrent cases, and failed DCR. First, the specimen collection was done with the help of sterile cotton swabs swiping against the lower conjunctiva, irrigation of the lacrimal drainage system, or applying pressure on the lacrimal system, and any spontaneous abscess pus was collected, or incision and drainage was done. 2 sterile swabs were taken. One was inoculated over the blood agar, chocolate agar, McConkey agar, and incubated overnight at 37 degrees Celsius, and then was taken for gram staining. And the swab 2 was directly taken for gram staining. This was followed by antibiotic susceptibility testing, which was done with Mueller-Hinton agar. A Kidbury-Bore disc diffusion technique was used, and the result was formulated as sensitive or resistant. For the methicillin-resistant Staphylococcus aureus and epidermidis, cefoxitin disc diffusion test was done, and the staphylococci, which was resistant to cefoxitin, was labeled as methicillin-resistant. The first 50 consecutive patients fulfilling the inclusion-exclusion criteria were enrolled in the study. So a total of 50 patients were taken, out of which 37 had chronic gastrocystitis and 13 had acute gastrocystitis. The age, 40 out of 50 patients were over 30 years of age, with a female predominance of total 32 patients. And maximum patients belonged to the upper lower class that constituted 46%. Comparing the culture positivity rate, a total of 35 patients out of the 50 had a culture positive discharge, and out of which 27, that is 77.2% of total, had a gram positive growth, and only 22.8% had a gram negative growth. Among the gram positive growth, Staphylococcus epidermidis was found in maximum cases, that is 28.6, and among the gram negative, Pseudomonas aeruginosa was the maximum, that is for 14.3%. And for the acute dacryocystitis group, the maximum number was found to be Staphylococcus aureus, followed by Pseudomonas aeruginosa, whereas for the chronic, maximum was found to be Staphylococcus epidermidis, followed by Streptococcus pneumoniae. For the methicillin-resistant group, total of 6 patients were found, out of which the incidence was more for the acute than the chronic dacryocystitis. So the overall antibiotic susceptibility for the gram-positive bacteria is as follows. It was seen that linezolid and vancomycin had a 100% sensitivity rate, whereas ofloxacin, levofloxacin, and ampicillin had the least, that was only 48.15%. For the gram-negative bacteria, amikacin had a 100% sensitivity rate and ofloxacin had 37.5. For the methicillin-resistant, it was only the vancomycin and linezolid that was 100% sensitive. So we can see RO represents the resistance to no drug, that is zero sensitivity. So none of the following organisms has had complete sensitivity, and around 40% had resistance to more than 5 drugs. So since dacryocystitis can be life-threatening, it can cause to orbital cellulitis, orbital abscess, meningitis, cavernous sinus thrombosis. Hence, that is why it is so important to treat it properly. The female predominance was because of the smaller nasolacrimal canal diameter and hormonal variables. So as the pattern of the predominant bacteria was seen in chronic and acute, it can be concluded that more virulent bacteria like Staph aureus are responsible for acute cases, and indolent like the epidermidis are for chronic. For the methicillin-resistant cases of the 6 patients, it was more seen in the acute dacryocystitis, as it comes out to be more aggressive in presentation with acute onset of symptoms. The possible explanation for the high susceptibility of amikacin in the cases of gram-negative is because it is not very frequently used in our community. So the broad-spectrum antimicrobial agents are commonly prescribed empirically to treat bacterial infections without definite diagnosis. Such practices are adding to the already existing natural antibiotic resistance mechanisms of bacteria and might be responsible for the relatively higher prevalence rate of resistance as in our current study. So the knowledge of the underlying etiology of dacryocystitis contributes to the choice of antimicrobial agent. Data on the regional distribution of the pathogens and their sensitivity helps in empirical antibiotic. Thank you.
In your opinion, which drug would be more feasible in case of chronic dacryocystitis?
So usually in our country, the most prescribed are the fluoroquinolones. But in my study, they are not 100% sensitive, and a higher resistance has been because of this, especially for ciprofloxacin followed by moxifloxacin, ofloxacin. So if the patient is coming to us without any prior use of antibiotics, we can go for a culture sensitivity. And on the basis of that, if it is gram-positive, as we saw, vancomycin and linezolid are the most 100% sensitive, and if it comes out to be gram-negative, we can go for amikacin.
So I mean, while on the basis of evidence, it does definitely, it sounds good, but I don't think in an OPD we can, if a patient comes with a lacrimal abscess, or an acute dacryocystitis, can we afford to wait for the sample to go into culture sensitivity for 48 hours and then initiate antibacterial or antibiotic
So in
treatment?
such cases, we can directly go for just the gram stain. That is why the 2 swabs were taken. One, we did go for the culture. The second was directly for the gram stain. Also, in such emergency cases, we can do that.
Right. So gram stain would just tell us if it is a gram positive or a gram negative organism.
Yes.
And in your gram positive organism, majority was Staph epidermidis,
Yes, sir.
which were 77% sensitive to amoxicillin clavulanic acid. So why can't we skip the gram staining and start on augmentin anyways?
Yes, sir, we can do
So
that.
what I meant to say is in terms of and also a lot of drugs that have been tested through to which we are seeing, say for example linezolid and amikacin, like say for example amikacin is not available orally, it has to be given only intravenously.
Yes, sir.
So how justified are we in starting IV treatment for acute dacryocystitis is another issue. But I think it's a good paper that gives us a good comprehensive spectrum of all organisms and sensitivity. So I think there's definitely some merit in the data. Amikacin is not available.
Amikacin.
And one more thing just to correct. I don't know what the other panelists think, but I don't think dacryocystitis is life-threatening.
No, it's not life-threatening.
If not treated, it is life-threatening for the oculoplastic cells.
Okay.
Thank you, Dr. Ali.
Thank you.
Next.
Next paper is by Dr. Ravi Ranjan. Repeat DCR. A small change can lead to big results.
As published in various journals, success rate of external DCR is 85 to 97%. In spite of excellent success rate, there are large number of cases with failure typically due to these causes. The aim of this study is to assess the success rate of repeat DCR by a small changes in surgical steps, and this is a prospective, uncontrolled interventional study consisting of 134 patients of LDCR from March 2011 to December 2020. And all these surgeries were done by a single surgeon to minimize the outcome bias of the surgical experience. And the incision were made on previous surgical scar, and intervening fibrous tissues were excised, and roughly 1 to 2 mm of the lacrimal sac around common canaliculi was saved, because it is always difficult to get sufficient flaps for mucosal anastomosis in repeat surgery, so that the sac remains as a disc with punctum nuts medial, similar to a funnel. And here A is sac remains, and the B is tip of the Bowman's probe coming out of common canuculi, just showing a landmark. A 10 mm Arugas bone trephine was used to make ostium in the nasal bone and nasal mucosa, so that remaining entire part of the sac was sutured with subcutaneous tissue and periosteum of the medial side. And on 5th postoperative day, syringing of 1 ml of 0.4 milligram per ml of vitamin C is syringed in newly formed passage, and these all cases were followed up for 1 year. And this is nasal endoscope after 1 year. Videos. Yeah, this is nasal ostium. Yeah, these all cases were followed up. These all cases followed up on 5th day, 1 month, 3 months, 6 months, and 1 year. And at each visit, the surgical outcome was assessed anatomically and functionally. Anatomical success was defined as patency of the newly formed passage on syringing, and functional success was defined as tearing assessment using Muck score. And epiphora of grade 0 on 1 was considered as success. And please come. For comparison of this study with previously published study, a meta-analysis were performed using MedCalc software. And since performing meta-analysis is not the primary objective of this study, that's why I'm skipping the statistical data. And this is the tabular representation of comparison of my study with other studies. And one thing I want to highlight, the p-value for this study is less than 0.001, that is significant. Result of 134% over 10 years, 131% were successful at the end of mean follow-up period, that is 12 months, and 2% complained of PP4 of grade 2 or more, and a sticky eye despite successful syringing and patent. Patent newly found passage, or 1% failed in syringing, and anatomical success rate is 133, that is 99.2%, and functional success rate is 97.7%, that is 131%. And personal communication with many ophthalmologists revealed that the failure of the procedure and tedious flap making in DCR are the main cause of reluctance from this surgery, and as a result DCR is ignored by many eye surgeons, and lacrimal surgery is increasingly being undertaken by ENT surgeons now. And in an era where other specialties are always looking to widen their surgical spectrum, we are losing our domain by ignoring this. And that's why we conceptualize this method to overcome the problem and make the repeat surgery easy to perform with successful result with short learning curve, and changes we made use of Aruga's bone trephine, and approximately 1 mm to 2 mm of the lacrimal sac was shaved around the common internal opening, and 1 ml of 0.4 milligram of mitomycin syringing in newly found passage on 5th post-operative day. And because the safest and most effective dose of mitomycin C is somewhere between 0.2 milligram and 0.4 milligram. That's I use here 0.4 milligram mitomycin, and we used 1 ml of 0.4 milligram per ml of mitomycin syringing on 5th post-operative day, so that the antibiotic property of mitomycin is utilized maximally, as it is not diluted by bleeding from nasal mucosa, and better coincides to early proliferative phase of wound healing, which start from 4 to 5 days of tissue injury. On conclusion, the success rate of this study is significantly better than previously published reports despite large sample size, and we conclude and recommend this method because this method is easy to perform with reliable and comparative results, needs no costly instruments, can be used for mass surgeries, camps too. And certainly my operation is not for them, but it is a boon for the masses. This is my references. Thanks to, especially thanks to Mohammad Javed Ali from LBP, Dr. Dhiren and ENT surgeon, and Dr. Mr. Lokesh, my aesthetician. Thank you.
Yeah, go ahead.
On good.
Actually, I am doing it in repeat surgery, and it is for adult. Yeah.
The mitomycin C that you used was used only for syringing at that on the 5th day for one.
Yeah.
And was it a fixed amount in terms of ml that was injected?
1 ml.
1 ml.
1
And
ml.
so my question is, if 1 ml of mitomycin C is irrigated through the ostium, most of it would drain into the nose and the mouth.
Actually, this is already studied by ENT surgeons. A very long study by some Dr. Lakhandeep, or some, you will get it. This is not harmful at all.
You know, it is not harmful. In fact, we have studied at different concentrations. So we've taken nasal fibroblasts and put it, in fact, Dr. Javed Ali is a co-author of that paper, where nasal fibroblasts were cultured and my mitomycin C at 0.1, 0.2, 0.3, 0.4, 4 concentrations for 1 minute, 2 minute, 3 minute, 4 minutes were seen and then observed, were placed for different durations and then taken out and seen. And the anti-fibrotic property was most effective, like you said, at 0.4 milligram, but for 2 minutes. Anything less than 2 minutes doesn't inhibit inflammation or fibrosis.
If you are syringing now, it will just for 5 minutes and more.
Correct. So anything above 4 minutes induces apoptosis and cell necrosis, and anything less than 2 minutes doesn't inhibit fibrosis.
In my study, because I have done it endoscopy and everything, there was nothing like that.
Right. And would you recommend this technique of using the bone punch for primary cases also?
Yeah, I have done more than 3,000 cases now.
So
I am doing it for 2002.
So in a primary case where you've taken out the bone punch, the bone through the punch or through that the Aruga's
Trephine.
Yeah.
In repeat case, how do you still find the bone, or is there new bone that you remove it?
Most of the cases cartilaginous bones.
Okay, it's scar tissue.
Yeah.
But in
case you may not need Arugaz.
Nowadays, I am doing with every cases where it is new or repeat surgery, sir. Because it is that much easy, it will take only 30 to 35 minutes.
Just one question apart from the topic. So since you've been doing so many lacrimal surgeries, you just mentioned 3,000 cases. So in your series of failed DCRs, do you think the failure is because of a poorly performed prior surgery, or is it because the surgery has been done well, but it is mainly fibrosis which has caused the failure?
In my cases, it is most commonly due to selection of wrong site.
So in short, it's like a poorly performed prior surgery and a little bit of the sac mucosa is there to salvage.
Whatever I do in nowadays, most are the referred from other doctors, not mine cases. Mine cases has only 1 or 2% as yet. About 2,700 cases I have studied, only 36 cases.
Yeah, so they always say that if your failed DCR comes to yourself, it's always more difficult to treat than treating someone else.
okay.
Thank you, sir.
Okay. Next, sir. Next, sir.
Arugaz used to do this surgery and coined dacryorhinostomy in his
Next.
Next is Dr. Barinder Kumar Bain. Prevalence and association of vitamin D deficiency
And dry.
and dry eye. Okay.
A very good
Lacrimal
afternoon to
में
one
कहाँ
and
से
all.
Hmm?
Myself Dr.
Yes, sir.
Barinder Kaur Bains, Associate Professor, Punjab Institute of Medical Sciences, Jalandhar, Punjab. Today I am here to share with you all a cross-sectional study to ascertain the prevalence and association of vitamin D deficiency and dry eye. So to introduce the topic to you, dry eye syndrome is a chronic ocular surface disease with symptom of irritation, dryness, grittiness, ocular fatigue, redness, burning sensation, and soreness. Dry eye is said to be one of the most common disease with which the patient visits an ophthalmologist. So if we go by the definition, as according to TFOS, that is Tear Film and Ocular Surface Society, the dry eye is a multifactorial disease of the ocular surface characterized by a loss of hemostasis of the tear film and accompanied by ocular symptoms in which tear film, instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological role. So here you can see it's a multifactorial disease. There are numerous factors that we already know that they cause the dry eye, both evaporative as well as aqueous deficiency type of dry eye. As you all know, autoimmune diseases, arthritis, chronic use of topical drugs, they all are known causes of dry eye. Now to this list, recently the vitamin D deficiency has been added, but a causal association is yet to be established. This study was carried out to establish an association between dry eye and vitamin D deficiency. Objectives to correlate prevalence of vitamin D deficiency in all the dry eye patients visiting the IOPD and to correlate prevalence of dry eye in vitamin D deficient patient diagnosed in medicine and orthopedic department at the tertiary care center, and to determine the association between dry eye and vitamin D deficiency. Methodology: after taking the ethical approval from the institutional ethical committee and consent from the patient, informed consent from the patient, total number of 101 patients were enrolled in the study and divided into two groups. Group 1, where all the vitamin deficient patients referred from orthopedic and medicine department who are subjected to various diagnostic tests in the IOPD for the dry eye. In this group, the prevalence of dry eye was calculated. Group 2, all the dry eye patients diagnosed in the IOPD who were subjected to serum vitamin D level measurement. And in this group, prevalence of vitamin D deficiency was calculated. Then the association between the two was calculated using the chi-square test. Exclusion criteria: children below 18, pregnant, postmenopausal women for obviously the estrogen and hormonal association with the dry eye, history of any refractive ocular surface or intraocular surgery, chronic use of any eye drops, pre-diagnosed ocular surface disease, or contact lens users. They all have been excluded. And the criteria chosen for the diagnosing dry eye, they are the Schirmer test, tear breakup time, ocular surface disease index, and fluorescein staining score. Any patient having one out of these 4 tests were labeled as dry eye. The Schirmer test measurement has to be less than 10 millimeter of the strip, tear breakup time less than 10 seconds, OSDI, which is a questionnaire based score, that is, it has to be less than, more than 12, and the fluorescein staining score, which is about like the ocular surface is divided into 5 zones, and it has to be not more than 15. And criteria for diagnosing vitamin D is by using chemiluminescence immunoassay, and the levels less than 12 nanogram per DL were labeled as vitamin D deficient. In group 1 out of 51 vitamin D deficient patient, 10 patient, that is 19.6, fulfill the criteria for dry eye, and in group 2, 17 out of 50 dry eye patients had vitamin D levels less than 12 nanogram per DL. And we observe a significant association between vitamin D deficiency and dry eye having p-value less than 0.01. So these are the results showing in the vitamin D non-dry eye subset and the dry eye subset in the vitamin D deficient group. So here the levels of vitamin D are less than 12 ng per DL, and the tear breakup time and the Schirmer score and all the criteria, they are falling into the dry eye, and in the non-dry eye subgroup there is a vitamin D deficiency. And so here I would like to just say that the deficiency, vitamin D deficiency subgroup had a dry eye patient which are 10 in number out of 51. So in the other subset where the dry eye patient of vitamin D deficiency versus non-vitamin D deficiency subset, here the non-vitamin D deficient patients, in which we had seen that almost everyone, they had the dry eye symptoms. The criteria used for the dry eye, they had been positive in that case. Association using chi-square test, the p-value came out to be less than 0.01. In this discussion, since we have evaluated the prevalence of dry eye and vitamin D, it came out to be 19.6. The population in the population of vitamin D deficiency, the prevalence of dry eye was 19.6, and the prevalence rate was much higher in the vitamin D deficiency in the other studies, where it came out to be 74%, which is not in accordance with our study. In another study which had comparable result to our study, prevalence of dry eye in vitamin D deficiency patient was reported to be 10.3%. In study population of dry eye patient, that's group 2, the prevalence of vitamin D deficiency was 34%, which is comparable to the study done by Zhang CH et al., where it was reportedly 41% of dry eye patient had vitamin D deficiency. So we found a significant association between vitamin D deficiency and dry eye in this study, and the limitation of the study was its cross-sectional design, which preclude any conclusion regarding the causality, and the severity of dry eye was not correlated with vitamin D levels. So dry eye and vitamin D deficiency have a positive correlation. However, all the dry eye patients do not have vitamin D deficiency, and all the vitamin D deficient patients do not develop dry eye. A causal association between vitamin D deficiency and dry eye need to be explored. So we warrant further study to see the effect of supplementation of vitamin D in dry eye, to see whether it is a causal or association or not. References. Thank you.
What are the functions of vitamin D in helping or you can say that it helps in dry eye management? what are the functions of vitamin D?
So it is likely to be the goblet cell concentration on the conjunctiva. So they are vitamin D is helpful in that. And so the hormonal disturbance, be it vitamin D, be it other hormonal thyroid disease and these estrogen level, they all are known to cause the goblet cell density, decrease in the goblet cell density.
In a study, it has also been seen that it works as a the inflammatory markers, reduces the inflammations also.
So nowadays we have little refined tests like lactoferrin measurement in the tear film. They're also coming up. So.
Okay.
Oh, thanks.
Thank you, Dr. Kaur.
She has taken extra time.
Dr. Pragya Saini?
She has taken extra time.
हाँ.
उसे तो ठीक ही था इसका.
Dr. Pragya is speaking on update on the long-term outcome following the management of incomplete punctal canalization.
Yes, sir. Good morning, everybody. Good morning. This is okay? Okay. Good afternoon, everybody. Sorry. So my topic for the day is long-term outcomes following the management of incomplete punctal canalization. So let's start from the beginning. The lacrimal canaliculi, they formed between the lateral nasal processes and the maxillary nasal processes. This starts at about 30 weeks, 30 mm stage of the embryo. This continues till about 130 mm, where 130 mm stage, where finally the hollowing starts due to apoptosis. And this is complete at the time of birth. So although we don't exactly know the process through which the incomplete punctal canalization occurs, we believe that it is during the apoptosis time at birth where that is absent and that causes the incomplete punctal canalization. So classification, this was done in 2013 by Dr. Ali MJ and Dr. Nayak. So there was an internal membrane and an external membrane variant. So the internal membrane variant is starting at the internal part of the punctum, and it is slightly vascular fibrocellular membrane. The external is overlying the punctum on the external part. It may or may not have vasculature, and then there is a balloon variant which is a part of the external with a dome-shaped elevation. The rest of the anatomy is completely normal with respect to the lid margins. On our study, this was a retrospective interventional study over a period of 5 years. We used nettle chip punctum dilators for the membranectomy. Initially, we used a rapid tapering punctum dilator, and to complete the process, we used a broad tapering punctum dilator. So our data included demographics, clinical presentation, laterality, types of punctum membrane formed, and associated lacrimal abnormalities, management modalities, and long-term outcomes. So we had total of 98 puncta of 62 eyes of 46 patients with an average age of 12.5 years of age. Range was 2 to 35 years, and the female to male ratio was 1:1. So here is what we did. On examination, it was mostly clinical assessment on slit lamp, which revealed the slight membrane was present over either the inner layer or the outer layer. And we attempted to do dilation with the punctum dilator, and then a patent punctum was shown as shown in the last picture here. So on symptomatology and laterality, the epiphora was present since birth in about 70% of the patients. It was bilateral in about 35%, and all 4 puncta were involved in 16%. Both upper and lower puncta of the same eye were involved in 55, and lower puncta only was slightly higher, which is 54, and the upper puncta was 46. So the external membrane variant was slightly more here, which is similar to the study published by Dr. Ali in 2013. So there's 62% here and 38% was the internal membrane variant. We had total of 78 puncta of 39 patients who underwent membranotomy. There were associated deformities present, in which 31% of the patients in total, 3 puncta required mini Minoka stenting. Partial canalicular obstruction was found in about 2.5% and canalicular stenosis in 1%. So both these required stenting. We had 5 patients with associated CNLDOs. 3 patients required DCR for this due to the bony obstruction, and 1% had a 3-wall canalicular hyperplasia. 3 patients had associated punctal agenesis involving the other puncta of the same eye. So on our outcomes, we had 100% anatomical outcome, but the functional was 97%. So our study added that it basically validated what the earlier management protocol was, basically membranectomy. Newer associations such as canalicular wall hyperplasia was found, and punctal agenesis involving the other puncta was found. So other insights were that membranectomy works best if the puncture into the membrane is performed by a fine dilator, which is a rapid dilator, and followed by a slow tapering dilator where we remove the membrane throughout. It should be complete membranectomy without any residual hanging membranes. Unlike punctal agenesis, it was not associated with any systemic disorders and rare to encounter functional failure post-treatment. Thank you.
Good presentation. Did you by any chance perform OCT? Because I know Dr. Ali performs a lot of OCTs on the
There was one
yes,
picture.
sir. We just getting to publish a paper on the OCT, and here is one of the OCTs that I performed on the patient where
so it was
you can
performed
see
in all the patients?
Sir, actually it's a retrospective study, so we performed it in the later years but not the initial ones. And it's a hyperreflective membrane which is shown here with the patent vertical canaliculi below.
What's a 3-wall canalicular hypoplasia?
So the vertical, the horizontal, and the membrane that was there, and the so it's
so basically there's an absent canalicular.
Yes, sir. So that was what the not treatable person. So that is how 39 patients we were including as treatment outcomes and not the 43 that.
So
we
in
had
those
total.
cases you really can't do anything, right?
No, sir.
Huh?
Thank you.
Thank you, Dr. Pagya. Dr. Gaurav, is he present? Yeah, please. This paper was awarded the best paper last year. Outcomes of inferior turbinate tarsal infracture for congenital nasolacrimal duct obstruction.
Hello everyone. This was a paper regarding the inferior turbinate efficacy and safety outcomes in cases of congenital nasolacrimal duct obstruction complicated by the inferior turbinate impaction. I have no financial disclosure. Congenital epiphora presents in almost 20% in the newborn cases, with 90% resolving in the initial first year and the 60% resolving in following year. The remaining are diagnosed as congenital nasolacrimal duct, which are treated with a variable intervention with the variable success rates. On reviewing literature, the unanimous consent was there that the success rate of the probing alone decreases with the increasing age, and which will subject them to more to the invasive DCR. Like it's 97% success rate for the probing in the cases of the children lesser than the 36 months, and merely 43% to the children above the 48 months. Whereas the inferior turbinate infracture in the complicated cases is less invasive and can have better outcomes when performed under nasal endoscopy. With this in mind, the purpose of the study was to identify the efficacy and safety of inferior turbinate infracture in cases of CNLDO in 69 eyes of 55 patients. Under general anesthesia, the punctum was examined for the nasal pathology, and The upper punctum was dilated with using the natal shift dilator, and the probing was done with an age-appropriate Bowman probe. After finding a bony block, the nasal endoscopy was done to identify the distal end of the nasolacrimal duct, inferior meatus, and inferior turbinate position. Using the lens spatula, the inferior turbinate impacted towards the lateral wall was medialized towards the nasal septum, and the patency was identified with the visualization of the nasolacrimal probe at the ostium, followed by this patent syringing. The patient was discharged on antibiotic and tapering steroid eye drops. The patient was followed up at 1 week, 4 weeks, 3 months, and 6 months, and then annually. All the patients were graded as successful with the patent syringing on the table and a negative history at the 3 months follow-up for the epiphora and discharge with a negative fluorescent dye disappearance test. Now coming to the results. We have reported a total of 55 patients with a mean age of 29 months, having duration for a mean of 27 months. It included a quarter of bilateral involvement, and the rest had the unilateral with 17 in the right eye and the 24 in the left eye. Here is a case of the 3-year-old child presented to our tertiary center with the congenital epiphora persistent even after the Krigler massage. He was diagnosed as a refractory congenital nasolacrimal duct obstruction. He underwent initial probing followed by an inferior turbinate infracture under general anesthesia. On table, there was a successful syringing followed by a 3 months also had a successful outcome. After syringing, 63 patients had a clear patent nasolacrimal duct, with 6 having the atonic sac. All but 1 had a successful outcome. Among the atonic sac, Krigler massage was advised, which led to the resolution in 2, and the rest were subjected to DCR. Coming to discussion, this table presents a comparable and summarizes the finding of the present study with the previously published data. In the previous literature, Atazeda and Khamenia has presented a resolution of CNLDO with inferior turbinate fracture as significant in comparison to initial probing. The main reason of this can be they have done the procedure under the younger age group without the confirmation of the inferior turbinate impaction, and it was done as a blind procedure, hence the insignificant results. Our case study was unique as it was done under the older children group, which had 69% more than 18 months with a successful outcome. Finally, we would like to conclude that inferior turbinate fracture is a quick, completely safe, effective intervention and can prevent from the more invasive DCR. We will be recommending that if a child presents to you younger than 12 months with an epiphora, Krigler massage is the first thing. The initial probing can be tried at 12 months of age. If failed, it can be repeated again, but it should have to be done under the nasal endoscopy. If an inferior turbinate impaction was found, the infracture will be the appropriate choice, and if failed, then we can go ahead with the DCR. These are my references. Thank you for your attention.
Thank you, Dr. Gaurav. Any question for Dr. Gaurav? Thank you. Well, the result will be declared by scientific committee. And do we have the photographer here? All the speakers can come here. We can have the photo, a group photo.